how to take decision for assisted vaginal delivery. You will take decision based on this decision-making algorithm by the RCOG. Safety criteria, it must be met. What are the safety criteria? That they had at least, okay, 1/5 palpable, okay, and reach the spine at 0, right? No excessive caput, no irreversible molding, okay? So that's mean, and the mother give consent, so that's mean at least, okay, you have so at least now you have a case eligible for instrumental delivery, right? So when to offer the instrumental delivery? Instrumental delivery can be offered according to the RCOG, okay? In primaries, according to the epidural or non-epidural, okay? If the woman with epidural, will be after 3 hours of the second stage. If she had no epidural, will be after 2 hours. If multi, will be after 2 hours with epidural or after 1 hour without epidural, okay? In all these cases, either the epidural is present or not, this is a confirmed delay in the second stage, right? I can discuss with the woman about the instrumental vaginal delivery in this case, okay? So you remember it as for primaries and for multi with epidural or without, this is 3 and 2 or 2 and 1. Okay, so remember it like this, right? Okay, so this is when you can offer the assisted vaginal delivery or offer a hand to the woman, help her or assist her in delivery, right? So where to deliver, where to take the patient for instrumental delivery? I can take her to the theater if it is a difficult assisted vaginal delivery. How to know it's difficult? Is it based on being primary or multi? No, it's actually mainly based on the head station, okay? So head, if it is 1/5 palpable, this is considered as a little bit high. So take her in theater. If the head in the mid pelvis means 0 station or +1, so take her also in theater. If rotation is required, and here I will say rotation is required mainly for the mid-cavitary delivery and low rotational deliveries. And we have explained the rotation. You have some feature suspicion of CBD, but not a contraindication. Like, for example, the patient that had double 2+. Okay? So, feature suspicion of the CBD. I will answer everyone question, please, my friends, after I finish. Okay? So we will ensure that the rest listening, okay, are focusing on what we say. Okay, guys? Select optimal place in birth if the woman have head, okay, is low but non-rotational. We have explained today what is the low and non-rotational, right? Low means that +2, correct? Okay. Non-rotational means that the rotation required is 45 or less, 45 degree or less, right? So if it is like this is considered as easy, straightforward delivery. You can do it in the room. If you have outlet delivery, can be also in the room. No features of cephalopelvic disproportion. This is in the room. Okay, guys? So far, we have the optimal place of birth. Okay? Decide where to take the patient to theater or to the room, depend on the estimated difficulty of the delivery. At 0 spine, this is in theater. +1, this is in theater. Low but rotational, this is in theater. Clear, my friends? using the instrument. So here in the guideline, they said, select the optimal instrument, right? First of all, for the woman that will give consent for, and the operator is well trained in. This makes sense, correct? However, they give you some advices as well, okay, in how to choose. Select the instrument that least likely to fail. So, dear friends, we are doing this to avoid sequential use of instrument. So, if you do have to compare between forceps and vacuum, where both are not contraindicated, okay? Both can be used in some cases, of course, and you know what are the cases, correct? So I have to choose forceps or vacuum. Which one is least likely to fail? That forceps, correct. Well done. Okay, so whenever there is a chance in the question to choose the forceps and this is the right answer, go for forceps, no problem. Okay, sometimes in the options, like the respected Dr. Kunji book, there was a question, where is the rotational ventouse delivery? Then so this is, it can be okay. Yes, because it's the only answer. We only have here vacuum. Correct application of instrument. When to do the correct application? First of all, you have to reassess, of course, the engagement, the position, station, and the syncretism. Seek second opinion if you are less experienced. Experienced operator to reassess. Like in the exam, if he told you that there is a new trainee, okay? So the new trainee need a supervisor, okay, and experienced operator, right, for reapplication and change of instrument or discontinue the procedure. But in the exam, most likely the question comes as you are the experienced operator or you are at least ST5, and that's mean you are capable of performing assisted vaginal delivery alone. Discontinue the procedure if not achieved the correct application with the above measures. So if you are not able to apply the instrument correctly, discontinue the procedure, right? A tempo of rotation, if indicated. A tempo of rotation, if indicated. If you're not able to achieve rotation easily, so senior obstetrician to check for correct application and correct rotation. Discontinue the procedure, very important, when to discontinue if rotation is not achieved with the above measures, right? So if you are not able to rotate with the instrument easily, okay, don't force rotation, right? Correct? So you have revised your correct application and the correct rotation technique, but it's not rotating. So stop, discontinue the procedure. Very important in the MQ because you will choose when to discontinue. Birth in direct occipital posterior position may occur when the vacuum or at low station forceps. So, dear friends, this is may. What is this? May. Okay? So, this notice is written only in theater, okay? Only in theater. Whenever you need rotation, do it in theater. If no rotation, you can do it in the room. If you have low station, okay? May, okay? With vacuum. So again, this is a rule or this is an exception? This is a rule or this is the exception? This is the exception, okay? What is the level of recommendation of may? May is weak, right? Recommendation or it's a strong recommendation? May is weak, right? So, dear friends, Yes. So, dear friends, the rule is still the rule. Okay? I will take the case to the theater if it is mid-cavitary or low need rotation. I will, okay, take the case in the room, or I will proceed with the instrumental delivery in the room if it is a low station, non-rotation, or outlet delivery. Clear so far? May is less than consider, my dear, even. Okay? So, you can have only one scenario where it's written like this, okay? So yes, your answer may not, it may be applied in the room, okay? But it's an exception, okay? When to attempt rotation? If progressive descent is not observed with appropriate traction. If progressive descent is not observed with appropriate traction, then what you will do? First of all, check the instrument is applied correctly. Can be the answer in your MQ question, right? So if he told you that the progressive descent is not observed with appropriate traction, then first of all, check. He can ask you what is the next step. Next step, check if the instrument is applied correctly. So can be a good option if the question asking about next. Reassess for features of cephalopelvic disproportion. Seek second opinion if less experienced. Experienced operator may revise approach. And here, what is the recommended management? When to discontinue? Discontinue procedure if descent is not achieved with the above measures. Discontinue vacuum assisted birth if two pop-offs of the instrument. So, dear friends, it's very clear and it's written in bold letters, okay, in the guideline, in the decision-making algorithm. When to discontinue the vacuum birth? When you have two pop-offs. Then I have in the question that there was, okay, two pop-off of the instrument. And some people think that I can still continue. Can I do that? Can I do that? No, you can't. So please choose only discontinue the vacuum delivery if there is two pop-offs. Reassess two pulls, okay? So pop-off of the instrument, this is when you are applying the instrument, you're trying to pull, but it's pop-off. Pop-off means incorrect application or there is something wrong, okay? What if the instrument is applied correctly, there is no problem, and here we speak about vacuum or forceps, and you are pulling down now, okay? So when you are pulling, okay, when to consider discontinue the procedure? Number one, if in vacuum-assisted birth, the head is not on the pelvic floor. What is the meaning of head on the pelvic floor, my friends? So I tell you that there is 3 pulls is done, okay, with the vacuum. And it descended from 0, okay, to +1. What you will do? What you will do now? Can you continue? Even if there is a descent occurred from 0 to +1, you will consider it successful to continue? No. No. Okay? If it is only on the pelvic floor, I can continue. Okay? So I am pulling the instrument. The instrument is well applied. The instrument does not pop off. And I am pulling. Now I'm pulling and one pull, okay, no descent. Second pull, minimal descent. Third pull, descent is okay, but it's a +2 now. And I'm using vacuum, okay? Shall I continue the procedure or discontinue? discontinue. Okay? So he's playing this with you in the exam, my friends. He's asking you, in vacuum assisted birth, the head is not on the pelvic floor. Okay? And birth is anticipated. So when it is only reached the pelvic floor, I can pull more. But not before the pelvic floor, nothing can be done. Okay? Maximum number of pulls allowed before pelvic floor is 3. So I have 1 pull and I didn't reach pelvic floor. Can I do the second? Yes, I can. I have 1 pull, right? If I have 2 pulls, can I do the third? Yes. But maximum is 3 pulls if I'm not reaching the pelvic floor. Okay? Prename, my dear. Outlet. Okay? So failed attempt at, yes, once again, my dear, if forceps birth and the head is not crowning with birth imminent. Okay, so head crowning at what station? Yes, okay. So we have, yes, more than the 3. So when the head is crowning, when the fetal scalp is seen, okay, visible, right? And not retracted anymore between the contractions, this is crowning, correct? So if you have forceps and the head is not crowning after 3 pulls, discontinue. So the thing in the exam that they give you, the head was at 0 station. You applied forceps. And after 3 pulls, it's now +2. What you will do? So appropriate management is discontinue the procedure, correct? Yes. So now you will turn to it to the cesarean, correct? So guys, what is the line, okay, of achievement where I am happy, okay, that my instrumental delivery is okay? The line of achievement for vacuum is the pelvic floor, reaching the pelvic floor. The line of achievement for the forceps is the crowning. If you have reached the crowning with 3 pulls of forceps, now you are safe, okay? You did not reach the crowning after 3 pulls, discontinue the procedure and go for cesarean. Correct, dear friends? Is it clear so far? So what is the key word for you in the exam to decide? The key word will be 2 pops, 2 pop off for vacuum, or if he told you 3 pulls, you will choose, okay, 3 pulls and not reaching pelvic floor with vacuum. This is to discontinue the procedure. If you have 3 pulls, okay, and head is not crowning, discontinue the procedure. What after discontinue? Go for cesarean section, my dear. Right? Failed attempt of operative vaginal delivery. Consider the consequences of failed attempt of OVB. Consider forceps followed by failed vacuum only with vertex at low station. So if I fail the vacuum and I have low station means +2. Can I continue with forceps after vacuum or not? Consider forceps followed by failed vacuum only with vertex at low station. Low station equal +2. So I will follow only failed vacuum if it is +2 by a forceps. Correct? That's why in the scenario of that question, it said that the woman only consented for vacuum. So can I now continue with forceps if she consented only with vacuum? Or vacuum? No. Right? But if the patient agree for vacuum after the vertex at low station, then I can follow failed vacuum with a forceps. Okay? No, we can't do best interest if the patient have the capacity, my dear. Right? Increased risk of trauma to the fetus and obstetric anal sphincter injury with sequential instrument use. So that's why we don't like it, actually. We don't like to apply two instruments. Increased morbidity for the mother with cesarean birth in second stage. Increased risk of fetal head impaction at cesarean section. So after the attempt of OVB, please remember, okay, this will be considered a failed attempt. Inform the neonatologist for increased risk of neonatal morbidity and complete the OVB performer, debrief the mother and partner and family, because this is considered as one of the events, okay, that is traumatic to the patient. The safety check after delivery will be paired cord blood sample, should be processed and recorded following the assisted vaginal birth, patient debrief, an incident report for adverse event, pain management, like non-steroidal and paracetamol. So in the exam also, when he asks you about postnatal anesthesia or analgesia, sorry, postnatal, best is to give combination between non-steroidal and paracetamol. VTE risk assessment and exclude voiding retention, physiotherapy, and physiological support because of the post-traumatic stress disorder. This is all about the decision making. Now it's the time, my friends, okay, to look to the chat and answer your questions. So thank you very much for listening.